Hello, I'm Dr. Jan Broomfield and I'm a speech language therapy consultant from the northeast of England, and I've come over to do a workshop for young Ballymun and for the therapists and managers in the Dublin area. Based on my research project, I did a research project looking at effectiveness of therapy and assessment provision in the service that I was managing at the time, and looking at how we could improve the service in terms of value for money, effectiveness and evidence-based practice. One of the key issues in terms of implementing the evidence that I found was looking at service delivery models and looking at triangles of need. So the triangle having at the base of the triangle having a universal model for health promotion and prevention and risk management. So being able to provide universal services to all children who may or may not have speech language communication needs, but to stimulate their language and speech and maximise their potential and minimise risk. That's a provision that I believe, and the evidence demonstrates, that needs to be speech language therapist led, supported by all of the other professionals that are coming into contact with all young children through their whole of their childhood and adolescence. Anybody and everybody, whether it's educational, healthcare, social care, voluntary workers, across all sectors can be involved, because all of them, when they're liaising and interacting with kids, are talking, communicating. So if you've got kids with communication difficulties or communication risks, then we all need to work together so we maximise the child's ability to understand and engage and interact. That enables us not only to prevent speech and language communication needs to be ongoing, but also the long-term impact in terms of behaviour, socialisation, academic achievements, literacy, and even preventing offending behaviours. So massive impact for health promotion for all clients. There's then a second tier, which is a less prevalent tier, 1 in 6 to 1 in 10 clients who have a delay in their communication. And those are the clients that the evidence would suggest, with mild, moderate delay, that guidance by speech language therapists, managed and monitored by other people, be that parents, skills, and supported and trained by speech language therapists, but almost a hands-off model, can be equally as effective, particularly with language delay. There is strong evidence to suggest that other people working with kids day in, day out better manage mild, moderate language delay and get better outcomes than having periods of direct speech language therapy. There's then a small proportion of the caseload, probably 1 in 10 at most, who have severe and specific difficulties, and it's those kids that the evidence will show that need direct speech and language therapy. So we need to be targeting and focusing, prioritising our services so that we maximise the effectiveness and maximise the cost effectiveness as well. And finally, I just want to say that actually we have lots of evidence to show that speech language therapy is a really effective mechanism and gets better outcomes than leaving kids either on really long waiting lists or in fact without therapy. So speech therapy works for children and it is cost effective. The Royal College of Speech and Language Therapists in the UK has recently employed finance gurus who have found that for every £1 or €1 invested in speech and language therapy over and above base level services, we will make an efficiency saving. The value for money, the added value for money is £6.53 per £1 invested. €1 invested gains £6.53 for the population, for the community, because of preventing additional support services in skills, from social services, from healthcare, from offending, from mental health teams. So absolutely cost-effective mechanism of managing communication impairment.